This topic, before I go behind the screen and we don't get much chance to talk about it. One thing I want to clarify that I've been where you all are not very long ago. I completed my MPhil in 2021. And during that, I started learning and talking about how to be queer affirmative. And I know that in the kind of hospitals that we're all placed, sometimes it can get very difficult to find those kind of spaces and whom to trust in order to be able to even use the terms such as queerness. So I will be operating from that assumption that it is a difficult topic to talk about, especially given the context and the situations that we're all living in. At the same time, this is an introductory lecture. So some of you may have already listened to videos and talks or read or been going through the life stressors and how to be queer affirmative, those sorts of things that we're going to talk about. So in case if any of you feel like it's becoming basic or redundant for you, please feel free to keep sending your insights in the chat box, and maybe it can be enriching for others as well during the conversation. Okay. Yeah, so one thing I do wish everyone types in the chat box right now is some of the expectations that you have from the session today. So it will help me as well ground as to what is it that you're all expecting, and maybe I can do some justice to it. Okay, so I think people are still taking some time to get used to sharing the expectations maybe on a topic like this. Okay, all right.
There's a message in the chat box, I think.
Out of syllabus, okay. All right, let's talk about that as we go along, if it is out of syllabus. Okay, so I'll just begin. So why we're talking about this today is because there's an assumption that people who are not cisgender and heterosexual, as in people who are queer or transgender, lesbian, bisexual, gay, anything that does not belong to the so-called norm of being heterosexual, are not sitting in rooms with us. They do not come to the general hospitals. They don't come to the general psychiatric wards. They're just out there somewhere. We don't know where. Maybe they exist somewhere in clubs and parties, dressing in a different form, but we don't know where they exist. That's one of the assumptions that a lot of us hold. And that assumption can stop people actually from entering into these hospitals and these general psychiatric wards, because we do not anticipate them entering the hospital and we're never prepared. They will not look very different. They will look like you and me. Some of them might dress a little flamboyantly, but that can be a personal choice. There can be certain cultural and ethnic groups such as hijras, who you might, based on their appearance, acknowledge earlier, rather sooner, that they are hijras and transgender. But there might be non-cultural, as in people belonging to no cultural groups as such, who might just be entering your hospitals every day in and out, but not be trusting to come out to you, because we don't think that they can be in our hospitals. So that's why we're talking about this topic today, how to be affirmative when there are people in our hospital spaces, in our PSW spaces, who might belong to the LGBTQIA plus spectrum and may not be able to understand whom to come out to and whom to trust. Okay. Okay. You want to understand, Sneha wants to understand about the pronouns and usage. All right, thank you. Other slides moving?
Yes, ma'am.
Okay, all right. So some of the expectations that I have from the lecture is seeing queerness as not pathological. I'm going to go briefly into how medical and psychiatric history has made homosexuality an illness, whereas it never was supposed to be there and does not belong there at all. One is that. Second, emphasizing the agency of queer people. So us not making assumptions and understanding that there are people whose voices need to be heard in psychiatric spaces as well, and being affirmative of the identities that queerness brings in. So it started along late 1800s when there were some studies that were done. There is a lot of controversy in the methodology that was chosen to conduct such studies, which were talking about how homosexuality is not the norm, but in saying that it was different, it became abnormal. Uh, there is literature right now, there's a lot of research that suggests that homosexuality as pathological also comes from colonial mindsets. There are many cultures, where indigenous cultures, where homosexuality, bisexuality, transgenderness is not pathological, is not different, it's not deviant. It's as part of everyday life as our other gender and sexual identities. It came into the DSM, somewhere still belongs in the ICD-10. The DSM has been a little more progressive in checking it out, and the DSM-5 is a little more progressive than the ICD-10. I'm not sure how many hospitals have already started using ICD-11, but ICD-10 still somewhere talks about heterosexuality, homosexuality, bisexuality, K terms में gender dysphoria or sexual dysphoria, which was also there in the DSMs called ego dystonic homosexuality. So there have been multiple studies done ever since then to bust these. Homosexuality is not an illness. It does not belong in the DSM or the ICD. It was never supposed to be pathological. And there are multiple studies that talk about how indigenous cultures have never considered homosexuality neither a crime nor a sin. Okay. There was also a groundbreaking research, a paper by Gail Rubin in 1984 that was talking about how there are certain sexual expressions or identities that are considered more acceptable than others. In saying that, there was, she described it in two circles, as the inner circle and the outer circle. The inner circle talks about these sexualities that are considered more acceptable or natural. And in the outer circle, she's put in sexual identities that are considered unnatural or abnormal. Mind you, she's talking about how these are perceptions made by society. These are not facts. These do not exist in the nature. These are made by societal structures in order to control sexuality and gender. Okay, so heterosexuality and sexual acts which are happening in the realm of marriage, monogamy, procreation, couplehood, relationship, at home without pornography, are all considered good, normal, natural sexuality, whereas any sexual acts that are happening in the realm of homosexuality or outside marriage, promiscuous, in more than one, with more than two people involved, using pornography, or in a park outside somewhere, using objects or sexual toys, are all considered bad, abnormal, unnatural sexuality. Ever since then, there's been a lot of talk about how we can identify these structures and also break them. It's not about just expanding the inner circle and including people who are outside within the circle. It's about breaking the circle in the first place. These perceptions and these binaries never needed to be existed for our society to function. What is needed is to be able to understand that people express in different ways, and they can be diverse gender and sexual expressions. So based on all this, there's a language that we use, which is normal and abnormal, and that's very embedded from our DSM and ICD classifications. Most of us who are obviously, because there's so much that we're doing during our MPhil PSW, that our entire language becomes very pathological. There might be some people who are trying to break that pathological language a little bit, but it does get difficult at times within the spaces that we're all in. So I want to bring this terminology in here. We will not be using the terminology such as normal and abnormal, because we've already established that LGBTQIA identities are not abnormal. They're not pathological. They are not criminal as well. But since, as we talked about, there are perceptions that exist, there are certain terminologies that we can use, such as normative and non-normative. Normative means which has been deemed as the norm by society. Okay? It does not equal to normal. Same, non-normative, which are existing outside the norms of the society. It does not make it abnormal or deviate. Okay? Normative gender and sexual expressions related perceptions will say that there are only two kinds of bodies, with a penis and without a penis. Yes, if you read literature that talks about extreme binaries of even sex, it will not talk about bodies, the earlier literature, it will not talk about bodies with penis and with vagina. It will talk about an inverted penis as a vagina. And that literally strips off every individuality, uniqueness, rights of people with not a penis. Those could be women or any other gender identities, or even sex assigned at birth as women. But yeah, it will all, normative terminology will also say that there are only two genders, as either male and female or man and woman. There are people, there have been talks about saying that sex is biological and gender is socially constructed. Yes, to some extent we can operate on that assumption while we go along the next slides as well. At the same time, I want to emphasize that there is research as well that has talked about how sex is also not as biological as we think it is. It is based on multiple factors and not just the external genitalia. It's very difficult for any doctor when a baby is born to be able to understand what is the hormonal configuration of that human, and it necessarily need not always be aligned with the external genitalia. But for today's lecture, we can talk about sex as somewhat biological and gender and as internal and socially constructed. And normative language will also say that there is only one sexuality, which is heterosexuality. Non-normative terminologies will say that there are multiple bodies. I'm not giving you examples because there can be many. I will go into some spectrums that we can talk about in the next slide. It will also say that there are multiple genders, and it will also say that there are multiple sexualities, and these are not abnormal. Sorry. Okay. So as I said that there are differences in what is sex, what is gender. I'm using the example of a gender-bred person. Sex, as we have been told from school and college, that sex is biological and it is based on the external genitalia. We're also going to use the language that it is assigned at birth. When a child is born, there's nobody asking the child what sex or gender you would like to belong to, or what do you think is your internal sense of gender. Obviously, we are all assigning it based on what we are seeing, especially the external genitalia. Gender identity is one's own internal sense of gender, whether they identify as somewhere along the masculine spectrum side of the spectrum or the feminine side or anywhere in between. Gender expression is the appearance or the looks that a person chooses to carry. Their entire personality, attire, body language will tell you what kind of gender expression they prefer. It could be masculine, feminine, or anywhere in between, or non-binary as well. Sexuality and sexual orientation is very different from the rest of the three, because it talks about who one is sexually or romantically attracted to. I've seen many people using gender and sexuality as synonyms. They're not. So there are people, when we talk about the alphabet soup, LGBTQIA+, yes, it consists of gender as well as sexual identities, but it does not mean that gender and sexual identities are synonyms. Somebody can be a cisgender person and be lesbian or gay or bisexual. Somebody can be a transgender person and still be heterosexual. It does not guarantee that somebody, since they are transgender, they have to be lesbian or gay or bisexual or pansexual only. Okay? So gender and sexuality are not dependent on each other. They can be very different. Okay. So some of the examples that you can probably see here, some of you might have to zoom in on your screen in case you can't see the slide. Assigned sex can be male, female, intersex. If intersex, you might know through medical records of the person, or if they tell you that they are intersex. Mostly intersexual characteristics would be identified through certain medical and hormonal tests. You can also use terms such as assigned female at birth or assigned male at birth if the person, the patient in front of you does not like to be called a female or a male. You can ask if they prefer to be called a person who was assigned female at birth. It means that the person did not choose to be assigned female, they were assigned by society. Okay. Gender identity, as we talked about, could be man, woman, could be trans. Cisgender and transgender, there's people sometimes confuse that we don't know what cisgender means. Cisgender simply means that whatever sex you were assigned at birth, you identify with that sex or gender even as an adult. So since I was assigned female at birth, till date I identify as a female or a woman. That means you're a cisgender person. If you do not align with that sex that was assigned to you at birth, you can explore your labels or the identity that suits you best. Could be non-binary, could be gender queer, gender fluid, trans. Yeah. Okay, gender expression can be feminine, masculine, androgynous, or gender fluid. Gender fluid would mostly mean that it does not um, it's not usually fixed. It could change depending on how the person is feeling, where they're going, whether they feel safe or not. And attraction, which we talked about, is sexuality or sexual orientation. Lesbian, gay, bisexual, pansexual, heterosexual, asexual, aromantic. And some of the umbrella terms that you, as we've already been talking about, one of the umbrella terms is queer. So anybody identifying with any of the above categories, probably apart from cisgender and heterosexual, could choose to identify only as queer. Or questioning. Questioning would mean that they have not yet arrived at a label for themselves which feels most aligned with how they feel or how they experience their gender and sexuality, and they could be on the questioning spectrum. They might have already figured out that they're probably not heterosexual, and that's why I don't want to be assumed as heterosexual. Okay, so I want people to again think, and if somebody wants to chat, type in the chat box, or if anyone wants to unmute and say some of the common myths that we've all heard, we've been raised knowing about homosexuality, queerness, or transgender people, any of the myths that come to mind.
Hello, ma'am. This is Sonali from Mental Health Institution, Odisha. Ma'am, in most of the community areas, it was considered as a sin. Like if someone belonging from LGBTQ community, he or she, like whoever the person is, it will be only considered as a sin person, and whatever the karma he has done, it is only of because of that the person has become so.
Yeah. So there are religious, cultural scriptures that we have been told uh, uh, have called homosexuality as a sin. Uh, we've had a lot of literature that says that it's not just psychiatry or science. Science, law, and religion, all three have been complicit in making homosexuality as illegal, pathological, or being misunderstood. Any other myths that people might want to share in the chat box? Yeah, sexuality can be changed by medicine and also needs to be changed. Even before, because we've had a lot of um, position statements from APA and even Indian Psychiatric Associations talking about how conversion treatments are banned because they cannot change sexuality. But many of them have taken time in also saying that it need not be changed. It's not something that is wrong or problematic. It's the perception towards that person that is problematic. So what needs to be changed is the stigma around it, and not the person's sexuality or gender expression per se anyway. Okay. Yeah. People can't be both religious and very difficult lines to walk on. Thank you for sharing this one. I've seen many people struggle with um, because there's a lot of internalized homonegativity as well, that puts it in a dilemmatic position with one's own faith. And there might also be abandonment from cultural and religious spaces, as we've seen a lot in from Catholic spaces from the West. But yeah, very difficult lines to walk on when one is trying to understand their sexuality as well as keep a grounded foot in their faith. Okay, so I'll go back to slides. So homosexuality or queerness can be a choice. I am not a very big fan of the word choice here, but it's definitely not something that anyone is choosing. Heterosexuality is not a choice, so why should homosexuality or any other sexuality be a choice? It's something very inherent in a person. Homosexuality arises as a result of childhood sexual abuse. This is something that I've heard a lot, and it will come to you for sure as psychiatric social workers or as mental health professionals. Even when you go out of this training, it will keep coming to you through families, through practitioners saying that since this person was abused as a child, they've become homosexual. There's no correlation between sexual abuse, whether in childhood or in adulthood, and sexuality. Yes, there can be trauma that a person can be carrying, but it has no relation whatsoever with their sexuality. People who are queer are harmful and violent. There's a whole talk about how gender neutral washrooms will face violence from transgender people, whereas there's been a lot of research that's told that it's not really transgender people who can be harmful or violent. Rather, it's the cisgender people who have been harmful and violent towards or against transgender people in gender neutral or any other washrooms. People who are queer spread diseases. We've been hearing this since the 1980s, and it even finds creeps again when we recently are talking about monkeypox disease as well. Queerness needs to be and can be cured through corrective or conversion treatment. We've already talked about this. It need not be changed, and it cannot also be. I mean, cannot is a separate question. It need not be changed in the first place. Another one that I wanted to add, that which I said in the beginning, that queer people outside exist somewhere outside. We don't know where we are, and I have never known a queer person. That's statistically highly unlikely. If you've actually genuinely never known a queer person, there it means that you are inadvertently not creating a safe space for anyone to come out to you, because statistically it's not possible that you've never come across a queer person. Okay, so some of the life stresses that I want to talk about from Ketki Ranade and Shruti Chakravarti's manual written in 2013. Many of you might have already gone through some of the latest manuals in this, or you can also find them on Mariwala Health Initiative's website. So they're talking about certain life stressors which exist because of the discrimination and stigma that exists against queerness and transness. These stressors need to be located outside as well, as in the stress source of these stressors is outside. There can be stressors in terms of self-acceptance. We are all raised believing that we are cisgender and heterosexual, and the moment you start realizing that there's something different, there's a lot of guilt and shame that's induced because of the socialization that we've all had. There can be issues in coming out. So it is also about the safety of the person who's choosing to come out. They may or may not feel safe in the moment or with the people that they're in coming out. There is violence and abandonment that happens very often. And also people are outed without their permission many times in psychiatric spaces as well. There's invisibility, so there's always an assumption that queer people look different, so that's why anybody who does not outrightly look queer will be assumed to be cisgender and heterosexual, and that can create a different a stress in the sense of how that person wants to be seen. There can be relationship issues, we'll talk about that as well. There's discrimination, there's overt violence that we've been hearing a lot from the American context, probably Indian as well, but it does not get as much media limelight as it has somewhat been getting in the American context. There's a lot of hate crime that happens, and there can be mental health concerns. With mental health concerns, sometimes we as practitioners can make wrong decisions about saying that this person is anxious or depressed because of their sexuality. That's not the case. That's never the case. The person may be having mental health concerns because of the way their sexuality is perceived. They would also be having mental health concerns irrespective of that. So there's also this assumption sometimes when even if we've seen well-intentioned people who have gone through processes of becoming queer affirmative, assume that if a gay man is walking into the clinic, their depression is because they're gay, or it has to be connected. It may not have any correlation whatsoever. They are gay, probably. And they might even be talking about it openly, but still their depression, anxiety, any other mental health concerns could be because of any XYZ reason in their life. This is something that I've put from a recent paper that I wrote from my MPhil work. It was about queering couple and family therapy, and I was trying to understand counselors' perspectives of couple stressors, especially in context of lesbian and gay couples in India. And similar concerns were brought out. So for example, is erasure and invisibilization of their couplehood. They're not seen as a couple, they're constantly seen as roommates or best friends or even sisters. Coming out as a couple is another stressor. A person may have been out to people around them as an individual, but it's another life event to come out as a couple as well. There are lack of queer scripts. Queer scripts means, as I said, that most of us are raised and socialized as cisgender heterosexual people. And we're told, okay, these are the milestones that any person would be having: getting married, having children, the way financial situations are dealt between husband and wife, the way living situations are handled. And these can all be very different in terms of queer couples. So how are we talking about these scripts is also important. And health inequities. It's very difficult for queer couples and individuals as well to access health, whether for physical health ailments or mental health ailments. It's very difficult to explain some of the stresses you might have been experiencing if you cannot come out to the person in front of you. Another short exercise. Can you think of some of the most common questions that we ask in psychiatric history taking, which assume that the patient is cis heterosexual only? There are many questions that we are asking right from the name and gender of the person till the very end in the mental status examination, which carry the language that this person we're assuming is cis heterosexual only. Can you think of some of those questions and type in the chat box or share if you want? Pronouns, yeah. So we are always assuming pronouns. Sexual fantasy. Megha, can you unmute and describe, or if you want to type as well, sexual fantasy. I'm not getting the sense. Sexual history, yeah. Most of the times we're only asking cisgender sexual history, and people might not be feeling safe to talk about queer sexual history as well. From the names itself, we try to assume, yeah, peer group information. Okay. Yeah. Okay. So some of the things that we already assume are the pronouns of the person, the sex and gender of the person. Most often we only ask if you've had a boyfriend or a girlfriend or a husband or a wife. We hardly ever try to ask if you have partners, if you've had, what does your spouse do? Where do they live? Menstrual cycle. From the appearance, we try to come to a conclusion, yes. Trying to understand pre-morbid personality and expecting them to have their gender friends or social circle. Yes, absolutely. All of this. So we're making a lot of assumptions throughout our history taking. Can you also think of some of the words, some of the basic words at least that we can change in order to make it gender neutral? We may not be able to change everything in one go, but some of the words that each of you can probably change or tweak so that the person sitting in front of you gets some clue that you might be open to queerness. People can keep typing. I'll still go ahead. I want to keep some time for question answers in the end. Okay, so you keep thinking about this. What can be some of the minor changes, at least, that we all can start making at our own ends in order to be a little queer affirmative in our practice? What does being queer affirmative in very simple terms mean? It's been described since the 1980s, and most of it has to do with how the practitioner's attitude and perception towards queerness is. So challenging homosexuality as pathological was one of the foremost ones when it was still pathological. We know that now it is not pathological, but the way people still talk about it, for example, as we talked about, when did you decide to become gay? Or what happened that you became gay? A lot of people in my practice even now ask me, when we go and speak to this client in the community, we can ask what happened that they got to know or they became. Nothing would have happened probably. Yeah, there can be experiences that you can ask as to maybe when did you get a sense that you are probably not cisgender and heterosexual, only if you think that the person is willing and feels safe to talk about it. Okay. One latest one that I also want to put in here as to what queer affirmative practice means is also challenging and understanding your own heterosexual and cisgender privileges if you are cishet. People who are queer in this group, I'm sure you've already been on this journey of understanding your queerness and may have met people who may be allies, who may not be allies. And people who are cishet here, who are sure that they are cishet, I urge you to identify some of the privileges that you have for being cisgender and heterosexual. And these are certain starting points where we can build some empathy towards people who are queer. All right, so some of the things that we can do at our own individual ends, at least in being queer affirmative in clinical assessment and intervention, using some gender neutral language, for example, using partner and spouse words in the initial, at least, when if the person says, yeah, I have a boyfriend, I have a girlfriend, that's okay. It's okay to continue with that terminology then. But if the person has not yet shared anything about their partners or spouse yet to you, it might be beneficial to ask in this gender neutral language. Clothing. I remember in our mental status examination, we somehow use judgmental words in describing the clothing of a person. So for example, this person came in and was dressed masculine, or wearing a lady's kurta or a men's jacket. So maybe you're not using those terms, we can describe the clothes that they're wearing. A long kurta with a solid pink pattern, or linen pants, or loose fitted jeans with a jacket on top. Not assuming gender and sexuality. I know we all do this. I also do this, I am sure. But just creating some bit of space when we are talking to the person in using some language that shows that we are open to understanding the person's gender and sexuality at a wider and more non-binary level as well. Okay, so locating the source of stress outside the person, as in acknowledging that these stressors are because of the discrimination and invisibility that this person might be facing, and not because of how they feel. Acknowledging the unique social and cultural stressors as well as trends. So we have talked about certain unique stressors that puts LGBTQIA plus people in a minority stressful situation as well. But there can also be certain strengths. For example, as, when you're talking about social support systems, people may not have support from their families of origin, but may still have a lot of support from families of choice. So explore that. Maintaining confidentiality, this is utmost importance. So I've seen people, and I again repeat, sometimes very well-intentioned queer affirmative people as well, not maintaining confidentiality and outing the person without their permission, whether to family or to colleagues as well. Please avoid doing that, even if we are going to our seniors in presenting the case history. Ask the person, if they've come out to you and they tell you that they are queer, ask the person if you have their permission to write it in the sheet and notebook, and if you have their permission to tell that to your colleagues, your seniors, and also their families. If they say no, respect that decision and do not talk about it. Okay. Validating gender expressions, relationships, and families of choice. You will be amazed at how even basic validations sometimes can make people so generous. I remember I was in training at Nair Hospital, and there was this queer couple who was obviously not outing themselves in the first place because they didn't know whether people will understand, but I understood. And the senior who was the primary physician at that time, the primary psychiatrist, also understood. And we took their permission, of course, in talking about it. And I was sitting with them separately, and I was paraphrasing and mirroring some of the stressors that I think queer couples go through, because I was also working on it at the time. And in the end, that couple was just so grateful, because I was able to understand their queerness and also validate it as something legit and so-called normal. When I said avoid words like normal, yes, but be also very context aware. I remember in situations where people obviously do not understand so many difficult jargon and academic words. So I know that in low-income communities where there are not many words that exist to describe queerness, you might you might be okay, in saying, if they ask that you are normal. There might be people who don't understand, अरे एक normal को question करते हैं, चलो normal क्या होता है. There might be people who may not be at that cognitive level of questioning what is normal and what is not normal. There might be people who might just ask कि मैं normal हूँ ना, मुझे बस इतना बता दो. And it's okay to say कि हाँ आप normal हो, lesbian gay लोग normal हैं. Sometimes doing that is also all right. So be aware of the context. Helping them find queer scripts. So not assuming that their financial situations, their living together situations might be all figured out. It might be very complex. It might be in mixed families or in very different ways that you may not imagine. So helping them understand what kind of different living together situations can exist is also something important. Expressing empathy that that you are aware of what kind of difficulties and struggles that queer people can face. Keep also space for intersectionalities, how it was pointed out that faith and religion and sexuality, sometimes it's very difficult to navigate together. So keep that space for queer people's caste, religion, and other social locations as well when talking about their struggles. Also do refer people out if they've come out to you. And if you are also looking for resources, want to help the person further, refer them out to queer affirmative support groups and helplines and resources. We usually do give out helpline numbers, even suicide helpline numbers, without checking if if the person is queer, and if the helpline is not queer affirmative, it can be even more harmful. So checking if the helpline that you're referring is queer affirmative. I will given an example of how a genogram can look like for people who are not heterosexual. So if you can see here, this section, there are symbols for identifying or representing gay, lesbian, and bisexual people. You can type this on your Google and you'll find this image very easily. Also, there's for transgender people, man to woman and woman to man. There might be people who are non-binary. I don't know if they have it here in this kind of picture yet, but at least you can use for transgender people who have already gone through surgical and legal transitions, perhaps. Yeah, and so couple relationship for lesbian and gay couples, or even for heterosexual and unmarried couples, you can draw this way. And LT would mean here living together. A lot of queer people obviously in India, because we don't have same-sex marriage as legal yet, they might have been living together for years and years, and you might not be able to show that in a genogram if you're not aware of this living together situation. Some of the ways in which you can build a queer affirmative overall space is using gender neutral language, asking for names as well, not just pronouns. Representation through brochures and posters in your space. It might, if it is difficult to do all of this in the hospital setting that you are currently in, you can still do that in your cabin space if there's that kind of freedom, or in your personal and independent private practice as well. Referring out and being aware of some of the queer events that might be happening around, connecting people to those queer events and spaces. So, for example, putting a poster such as this, ask me about my pronouns, and hello, hi, my pronouns are she, her, or they, them, or she and they, something like this can also make people aware that, okay, it may not matter to anybody who's not queer. They will not have a problem with it. But if somebody who's queer and not sure whether to come out to you or not, and if they see such a poster, they might have some assurance of safety of coming out to you. Some of these resources, if the organizers can make sure that these red lines are gone, people can take a screenshot of these resources and perhaps use them. Feel free to share them with your clients or your colleagues as well. And any comments or questions that you have, please feel free to ask.